This presentation focuses on an online survey study and meta-analysis outlining the management practices for West syndrome in South Asia. Why South Asia? South Asia comprises of developing countries with 22% of world's population and less than 2% of global income. Health infrastructure here is relatively underdeveloped. Although West syndrome is the commonest epileptic encephalopathy in infancy, there is paucity of published literature from this region, and available literature is mostly retrospective. Considering the poor access to neonatology and pediatric neurology services, there is a high possibility of huge disease burden of West syndrome here due to acquired structural brain insults such as hypoxic brain injury and hypoglycemic brain injury. The management practices here, though believed to be heterogeneous, are largely unknown. Hence, the objectives of the current study were to capture the prevailing practices for management of West syndrome in South Asia and to carry out a meta-analysis of existing literature on West syndrome. This was a descriptive cross-sectional survey study. Survey questionnaire consisted of 36 questions pertaining to epidemiological variables, diagnostic and treatment practices of responders. Questionnaire was shared with 223 pediatric neurologists and pediatricians across 7 countries. 125 responses were received and response rate was around 56%, with most responses from India, followed by Pakistan, Myanmar, Sri Lanka, Bhutan, Nepal and Bangladesh in that order. Male preponderance and an approximate lead time to treatment of 4 to 12 weeks was observed by 60% of respondents. Static structural insult was the commonest etiology identified by responders. Key problems specific to different countries included difficult access to pediatric age in Bhutan and Nepal and unavailability of ACTH and vigabatrin in Myanmar and Nepal. And there were licensing issues with vigabatrin in India. So responses for the first choice drug in West syndrome also varied from country to country. The most common response from India was ACTH followed by oral steroids, while for rest of the countries oral steroids were the preferred drug. Commonest regime for ACTH was maximal dose at initiation regime, which was followed in India, Sri Lanka and Bangladesh, while gradually escalating regime was favored in Pakistan. Maximum dose of prednisolone used was also variable, with the most common response from India being 3 to 4 mg per kg per day, while that from Pakistan, Bhutan and Bangladesh being 2 mg per kg per day. While Sri Lanka, Nepal and Myanmar used a dose of 5 to 8 mg per kg per day, similar to UK infantile spasm study protocol. The most common response for the total duration of hormonal therapy was 4 to 12 weeks. Most responders considered cessation of spasms for 4 weeks as complete response, and they advised repeat EEG to check for hypsarrhythmia resolution. Moving on to the results of meta-analysis, of more than 1,000 studies screened, 18 studies were included, which were mainly from 3 countries, that is India, Pakistan and Sri Lanka. There was no eligible study from rest of the countries. Meta-analysis revealed male preponderance with 68% of reported patients from South Asia being males. Besides, there was a predominance of structural etiology to the tune of 80%, while acquired brain insult was etiology in 68% of patients. This was higher in India to the tune of 71%, while it was lower in Sri Lanka to around 62%. And the pooled estimate for lead time to treatment and diagnosis was around 2.4 months, which is much higher as compared to the Western countries. And in India specifically, it was even more higher. It was around 4.5 months. While in Sri Lanka and Pakistan, it was nearly 1.5 months. For assessment of therapeutic response to hormonal therapy, only randomized controlled trials were considered for meta-analysis. Day 14 and day 42 response rates for oral steroids were much higher as compared to ACTH. This is because the largest study, which is a Sri Lankan study, used ACTH as an alternate day therapy, as compared to the Indian studies where the usual dose was a daily dose which was similar to that study. This is the probable reason for higher response rates to oral steroid as compared to ACTH in this meta-analysis. So peculiarities of South Asia in West syndrome management include preponderance of structural etiology, difficult access to pediatric EEG and non-availability of ACTH and vigabatrin in some countries, longer lead time to treatment, and low response rates to hormonal therapy. Thank you.